Welcome to the Vet Dental Show. I'm Brett Beckman. I'm a board-certified veterinary dentist, and we come to you every week on Wednesday to provide the veterinarian and the technician team some actionable things that you can use in your practice. And this episode is going to be a recorded episode that we've done in the past, not a podcast that we've recorded or not the Vet Dental Show, but actually some other information for you that we know you're going to enjoy. So sit back, enjoy, and we'll see you at the end of the podcast. The first question Christina Wirt had, and Christina asked, with the slab fractures that go into the gum line, I learned that this meant automatic extraction if the tooth is stable radiographically and no exposure of the pulp cavity. Can we remove the slab and monitor the tooth? Christine, I'm not sure where you heard that, but we do root canals quite commonly on teeth that are fractured with pulp exposure where that very thing happens. The problem with that is if that goes beyond that mucogingival line, and if you look on that image, that line is where the demarcation is, and it's kind of a oblique angle where the camera is, but the mucogingival line is between the attached gingiva and the unattached gingiva. So it's right between the pink and the more pigmented unattached gingiva. So if it goes beyond that, then it becomes a periodontal issue, and we can't resolve that. So in those cases, what we generally do is extract. There's very, very unusual instances where it may be a situation where the owner definitely wants to try to proceed without, but it's very difficult to assume that without advanced repositioning flaps, that we'd ever have a periodontally quiet area there. So it would require a lot of maintenance and probably eventually would result in the tooth being extracted anyway. But great question there. So post-op instructions for bonding and composite of teeth, do you have them on a soft diet for a certain amount of time like extractions? And Megan, that the answer to that is no, we don't. And a little further on that, Megan, just because I know probably the next question would involve this, or this might be the next question that somebody has. In our practice, if the area that we restore is significant, and let me qualify this, most practitioners are not doing restorations, and that really requires a wet lab where you're learning about restorations, you're learning how to do them, you're learning about cavity preparation and design. So it's not something that you can read a book and be comfortable with. You have to have the right equipment, you have to have the right bonding agents, right composite, the right magnification, and the right instrumentation. So this is not something that really in general practice we would be doing for the most part unless we've taken an advanced lab of some type. So Megan may have that under her belt, and that if so, that's great, but you as a general practitioner will not be doing these. You can certainly learn bonding and odontoplasty and bonding without a lot of hands-on in lab, but we still recommend that you do that. And so that's what she's referring to. If we have a case where we're doing restorations on a particularly large area, and it's a fairly young dog, it's not ancient, we are going to put on a cast metal alloy crown if it's a significant tooth and a significant volume of dent that's been exposed. And so that's the general recommendation, because in humans we know that restorations will fail sometime within 3 to 7 years. And I have not seen the recent research with that, but the bonding agents have not changed that much. And that's why humans put crowns on teeth. One of the reasons is to protect that restoration so that it doesn't break down over time. So if we assume that that's the same in our patients, if it's specifically a large tooth maxillary fourth premolar, mandibular first molar, which get the brunt of the chewing, as well as possibly a canine, especially in a working dog, then we will put crowns on those. If we don't have the ability to do sealants and the client won't do the referral, we just monitor these radiographically. Yes, and that's a good question. We need to really address that. And Samantha adds, do we recommend monitoring or client declines extraction? So I want to talk about that too and address that at the same time. So with that being said, as long as the tooth radiographically is okay, I would not extract a tooth that has a exposed dentin where we need to restore if the owner doesn't want to do anything. If there's periodontal disease or there's other questions with that tooth, and obviously depending on the age of the patient and the client compliance, otherwise we would almost never recommend extracting. We'd want to get that patient back and check that down the road radiographically. If depending on the age, again, you may see changes in 6 months. If it's a young patient, it may take 18 months to see changes radiographically or more in an older patient, so if they're going to happen at all. But the other thing that happens sometimes is the body will repair that, and it will form that tertiary dentin, which is like enamel. And so the body may take care of it without. If it's a particularly deep lesion, that's unlikely, but it's possible. Usually slow wear or abrasion will result in tertiary dentin formation and save the tooth as that wear continues, but not always. So again, radiographs are the way to go, and I think that addressed everybody's question there in that one question. So Michelle, welcome Michelle. Michelle is one of our recently joined veterinary dental practitioners in the program for veterinary dental practitioners, and we have this launch going on periodically throughout the year where we open this back up for new students, and this runs 8 months, and it starts now. Shell is in a little early. We let her come in a little early, and we sent a few emails out to people we know and got them the opportunity to come in early. So if you're interested in this program is just under $5,000 now. Added so much and added instructors over the last year. So if you think that you want to get involved with this and need more information, email or send Jennifer a private message there and then Facebook, or message her on Facebook with your email address, and we'll get that information to you on that. We're not going to take time to talk about it here, but welcome Michelle. Michelle just joined the program I think last week actually. So developmental groove, now that I know what it's called, any recommendations for making that area easy to extract? And that what I do is use the mesial cusp on that tooth, which kind of sits above the distal neck of 08, and I take and go through the mouth with the luxator, so from the other side, and then put that luxator elevator underneath the front lip of that in the space between 08 and 09, and use the bone to leverage that tooth and literally just, or that tooth root and crown, and literally just keep firm pressure on that and lift it right out of the alveolus, and that is very effective. It's we teach that in the wet labs along with a lot of other things we don't teach just in general, but that's a tip that we teach there, and so if you're interested in those, we're doing those. And if you guys would post that, anybody, Sonali, post the link to the main course page. It's got all of our live wet labs on there. But that's best learned with those techniques. And actually for you, Michelle, we teach that in the virtual wet labs that we do inside the veterinary dentistry practitioner program once a month. So those are just for you guys. We do those once a month. And good question there. And the other thing that we do with that is we also work between after we section. So we'll work the luxator elevator against each root, against itself. So one root against the other root. So if this is the mesial root and this is a distal root, I'm going to take that cupped end like this, and I'm going to wedge it between those two, and I'm going to try to lift, again, lifting up and away. And then when I go to do the distal root, I'll turn that luxator around and lift that up and away. And you can also work down as well. So those are just some tips to use. And that tooth, as long as you are comfortable and patient with it, it's not that hard a tooth to get out. Those roots are really big. They can be challenging. They can be ankylosed, and you can have some dilacerations on those root tips where they curve. But if that happens, probably want to refer anyway if you see any of that stuff radiographically, because then it really becomes a challenge. I hope you enjoyed this episode. There's a lot of actionable items in there that you can take and use in your practice immediately. So put those to work and enjoy the benefits for the practice lifetime in your dentistry service. And if you would, please go to iTunes, leave a rating and review, take a picture of that with your cell phone, and then post it on the Vet Dental Show Facebook page. Just go to Facebook, search Vet Dental Show in the search in the upper left, and the show will come up. And once you post that, we'll send you a free instrument use essentials course. So if you want that free course, again, all you have to do is go to iTunes, leave a rating and review, take a picture of the rating and review with your phone, and then post it on our Facebook page, The Vet Dental Show. So until next week, have a great week. Take care, guys.